So let's move on to the advanced stage, which unfortunately is the large majority of EGFR mutant lung cancer that at least I see and that's seen in this country. We're trying to make or optimize strategies for treating EGFR mutant lung cancer. We've made some significant headway. Of course, we started with first generation and second generation TKIs. They were compared to chemotherapy and showed response rate advantages, PFS advantages, underrepresented in the literature, quality of life advantages. But we didn't see any OS advantages when comparing TKI to chemotherapy, at least in the preliminary intention to treat analysis. We've learned recently of FLORA a year or two ago, maybe even more, showing a benefit not only in PFS, but OS when comparing osimertinib to first generation TKI. And I only mention that study because some of these new strategies that have come around are looking at first generation TKI. So Becca, you want to walk us through some of the strategies that are evolving in EGFR mutant lung cancer, combination strategies, and where we're going?
Sure. So in the first line setting, there are multiple different combination strategies being pursued. And in broad categories, I'll talk about two. One is combination with angiogenesis inhibitors, and the other is combination with chemotherapy. So first, the combination with angiogenesis inhibitors. There were some updates recently at ASCO that are worth just briefly reviewing. So NEJ026 was a study that compared first-line erlotinib versus erlotinib with bevacizumab in patients with activating EGFR mutations and advanced lung cancer. And they had reported a significant PFS benefit. The median PFS was something like 17 months versus 13 months. In the follow-up data for OS, the median OSs were not significantly different, which is in all honesty a little bit disappointing, but not that surprising either based on some prior phase 2 data that had been reported, randomized phase 2 that showed PFS benefits, but not OS. There are other angiogenesis agents being combined with the EGFR TKIs. Relay was published within the last year or so, and that looked at a combination of erlotinib with bev versus erlotinib with placebo. And there also they saw a PFS benefit, but the OS data were not mature. I think in general, it's a interesting scientific idea, the idea that if you improve tumor vascularization and improve drug delivery, perhaps it'd be better outcomes. But we have not yet seen an OS benefit here. And I think there is combination toxicity when you do the two together. So I personally, and I'd be interested in hearing what others say, I personally haven't offered this to my patients for the most part. Obviously, you would really like to see the results of the OC versus OC-Bev combination, and those data will be a little bit out in terms of when they come.
So maybe we can stop there just real quick before you talk about chemo combinations. When you mentioned Relay with, I think you meant ramucirumab with erlotinib.
Oh, yeah, sorry.
That's okay. That regimen is now approved, and it got approved probably 2 or 3 weeks ago, and we're in June now, 2020. Is there any traction in this regimen? It's a first generation TKI with ramucirumab. It's not with osimertinib. Is there any patient that you would consider using this for?
It's hard to think of a situation where I would really be saying, gosh, I really want to use erlotinib rather than OC as my TKI backbone. And with the kind of aggregate of data so far in angiogenesis combinations where there's been PFS benefit, but no OS benefit, obviously not in Relay reported yet, but in other studies reported no OS benefit. It's hard to imagine for me personally that I would be willing to take the added toxicity of adding angiogenesis agent to what I consider a not quite as good TKI.
Got it. And Josh and Luda, before Becca talks about some of the chemotherapy combinations, your thoughts on Relay? It's an approved regimen. Is there traction with anti-angiogenesis strategies with first generation TKIs? Luda?
I think the train has moved on. So this was a good idea at the time it was designed. But I think I agree completely with Becca. I will not use that combination. And neither am I ready to make a leap of faith jump of using angiogenesis inhibitors with osimertinib without having, osimertinib specific data, just because, as Becca mentioned, exactly toxicity. When we give an extra toxicity to our patients, we want to know why, and I don't have a why yet.
Okay, Josh, your parting shots on anti-angiogenesis and TKIs?
Yeah, it's interesting. I agree with everything that Becca and Luda have said. And the toxicity associated with angiogenesis inhibitors are really binary. It ends up being either no toxicity whatsoever or really, 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 really bad toxicity.
How many reallys was that?
That was a lot of reallys.
Okay.
It was enough reallys that it tried to bring the point home. Like, it's either nothing or it's, bowel perforation, hemoptysis, and clots. I mean, these are significant side effects that with a questionable benefit makes me less excited about using it. And in addition to that, I'm not entirely convinced that there's a impressive preclinical or clinical data to support the idea that VEGF blockade has special efficacy in the EGFR mutant population. I just don't believe that. Yeah. And so I think that I'm just as hesitant to use this.
Yeah, I eagerly wait the ECOG study of osimertinib plus bevacizumab versus osimertinib alone, which Becca mentioned.